Okay, folks. Thank you very much. If you could take your seats, we're going to reconvene. Thank you. Thank you very much. If you'd like to just close the back door and we will start again. Thank you so much. Thank you for coming back on time. The level of noise is an indication of a good day that has started, I think. So thank you very much for coming back so quickly. I'd ask Michael Ryan, Doreen Carpenter and Sharon Lane to come up and join me up here, if you would, for this session. And just before we move into this one, and this has been mentioned, I think, by a number of people already, the importance of the lived experience, the importance of the voice of those using the services and their families and the wider community. And this, I think, has been already mentioned by the outgoing chair and the members of NIMIC, that it was a really significant development, and indeed one that has now been replicated, looking at themes in other departments. And I think that sort of replication is a great form of flattery when people are taking your structures and copying them. So this panel is specifically looking at lived experience, engagement and recovery. And I was also interested this morning in the session that Ian was chairing the panel, the debates and discussions that are ongoing. It's great to see people talking about things like, are pilot projects a good idea? Or should we just be doing something else? And one of the roles I've played over the last few years in Sluntcare has been to deliver these webinars. We've done about 22 of them. They're online. And the idea is that we pick out elements of good practice that have been funded through the Sluntcare implementation funds. And they are, by any other name, pilots. But the beauty of the first round is that over 90% of those funded actually became mainstream projects. So whether it's using tech for people with diabetes at home, or whether it's supporting using tech for other long-term chronic conditions, and also funding things like social prescribing, which many people here would be familiar with. So that idea of using money to, sometimes it's not prove a point. I take John's point about some of these things are proven, but sometimes it is about setting up the best structure and see what works best and then copying that. So I do think imitation can be a form of flattery, and I love to hear that there's debates going on about whether or not we should be piloting. There are things we know, there are things you know, you've proven them, and the idea that they just get directly funded is, of course, the way forward. So, on to our next session. I'm going to invite Michael to speak first of all. And Michael Ryan is the National Head of Mental Health Engagement and Recovery with the HSE since 2019. He brings his own lived experience of mental health challenges and now enjoys a full life in recovery. Michael has a strong record of accomplishment in recovery practice and innovation, having worked as an advocate and as peer support worker before being appointed as Director of Advancing Recovery in Ireland. So I'm delighted to ask Michael to address us, and stay there or come up, whatever suits you, Michael, and then I will introduce our other two speakers when Michael has finished.
Good afternoon, everybody, and thank you, Grania, for the warm welcome, and thanks to the organisers of the conference for inviting me to speak here today. And it's good to see you all, and I can assure you I can see you all very clearly from up here. I'd just like to press a button. There we go. As Grania said, I'm Head of Mental Health Engagement and Recovery with the HSE, and just to tell you a little bit about myself, I've had a number of roles previous to that, as many people do. I also worked in education previously. I'm a family man, I like to grow a few spuds. I'm into a bit of gardening. I also have a dog. I got a new dog recently, and she's great. And I'm a bit interested in GAA, but we won't go into that because this is supposed to be about positivity and hope and not despair when you're from Mayo. But I'm also somebody who has, lived experience, and a lived experience of mental health challenges. And that's, a word we hear a lot about today, but do we really understand it? People say, that's my lived experience, that's my truth, whatever. So maybe it's no harm just to recap exactly what we mean about lived experience. And as I understand it, it's about living with a mental health challenge that has had a disruptive impact on your life, either personally or in one's own life as a family member, carer, or supporter. So lived experience also incorporates the experience of using services and achieving recovery. And lived experience is a form of expertise, and it's a set of knowledge. And there's just a reference there to the literature, that emphasises that point. Lived experience yields distinctive knowledge that is different to knowledge gained in professional or academic context. This can sit alongside and complement academic or occupational expertise generated through study or work. So there's some nice ideas about what lived experience is. But what does that actually mean? It's about the human experience. And when we're talking about mental health challenges and having lived experience, it's about what's it like as a person to experience a mental health challenge. And mental health challenges, we know, can take, many forms, along a continuum, from mild depression, anxiety to acute psychosis that needs, hospitalization and specialized care. But what does that feel like for a person? It feels very fearful because things are out of control. You don't know what's happening to you or what you're feeling. You're confused because you don't know what to do next. You feel stigma, you feel shame. People treat you differently. They talk about you as if you're not in the room. It can cause breakdown of relations because people don't understand you. Simple things like going to the shop can become impossible. The dreams of your life, they start to disintegrate. You lose hope, isolation, loneliness. And it can result for some people, hospitalization and, intense medical or other treatments. So it's a basic breakdown of life structures, often involving poverty, unemployment, homelessness. All those were part of my own journey. So it's important that when we're talking about lived experience, that we think about what the word really means. But there's also something called recovery. I'm in recovery today, so it's important to understand what that means. And recovery is not about cure. It's not about the elimination of symptoms, although that can be very helpful in progressing someone's recovery. In the literature, it's described there by Anthony as a way of living a satisfying, hopeful, and contributing life, even with limitations caused by illness. Recovery involves the development of new meaning and purpose in one's life as one grows beyond the catastrophic effects of mental illness. So again, that's a lovely definition, but in reality, what does it look like? And again, it's about the human condition. It's about being the best version of yourself you can be. I've heard it aptly described. Recovery is about having somewhere to live, someone to love, something to do. The aspirations of all our own hearts. It's something to offer everyone. And, we can all learn from the process of recovery. And I like that image there of the cliffs of Moher and the idea of horizons. When you reach one, you see something more beautiful beckoning in front of you, and you want to go on and see that. And recovery is like that. The first horizon might be trying to get out of bed in the morning and go down and make a cup of tea, go to the shop, get back to education, get a job. And that's all our journey. So that's what we mean by recovery, becoming the best version of ourselves. So lived experience, as I said, it's an expertise. So what are the benefits of it? The first and most important thing to say is, for people to use their own lived experience in their own care, is a basic human right, and you'll see the quote there from the United Nations Charter for Human Rights for People with Disabilities. I could stop the conversation there because that's enough to say that's somebody's right. We don't have to go any further. And we need, nothing about us without us is the mantra. But there are other benefits as well. And those are of a service improvement and a therapeutic nature. In services, it helps people achieve better recovery outcomes. It increases communication by involving lived experience. It takes a holistic approach. It supports integrated care. It builds capacities and skills both of service users, family members and staff. So lived experience has a huge amount to offer our services. In what way though? What are the applications of lived experience? So peer support people will be familiar with. And in the HSE now we have both service user, people with their own personal lived experience, and family peer support. We have family peer support workers present here today, I see. Recovery education, recovery colleges. So using your lived experience to help others understand, what recovery is, what lived experience is. We have 10 recovery colleges now in the HSE. We have peer and recovery education facilitators and staff, and just like to acknowledge the contribution of Mental Health Ireland in their work in supporting us in delivering mental health and peer education, in our services, and acknowledge indeed all the contribution and support of all our NGO partners. Some are here today as well. It's very important in service improvement, lived experience. So, we have an area leads for engagement in most of our CHO areas. We have engagement forums, we have lived experience co-production panels, we have peer researchers, PPI, and we have the Office of Mental Health Engagement and Recovery, which tries to oversee all that. So there's quite a lot of applications of it. What do we do in the Office of Mental Health Engagement and Recovery? Last year we published our strategic plan for the next 3 years, and it talks about core areas of work around integrating lived experience into service delivery. So that's around engagement, that's around peer support, recovery education, IPS, getting people back to work, and the implementation of sharing the vision. And you can check that out online by going to the HSE website. But there are challenges to integrating lived experience into services. How do we ensure that we really value lived experience? How do we make sure that we really take on board what it is and that we really do treat it as an equal expertise? How do we support people with lived experience? We're asking them to bring to work, a very core and personal experience that they have had. So for some it can cause emotional distress, vicarious trauma. So we have to know how to support them. The organisational structures we need to do that. Occupational health, are we able to bring in new grade codes and so on around these new roles? There's challenges for the organisation in terms of recruitment and so on. In culture, do we really understand what lived experience and recovery is and how it fits in and how it complements everyone else's role? And resourcing is always an issue. It takes time to build recovery capacity and lived experience, and sometimes it gets trumped by the urgent, but it is important. And the Minister earlier, talked about, recovery is possible, and recovery is, that wasn't timed.
Perfect time.
Hello, Minister. But But recovery is everyone's business, and it's everyone's business in the service. And, there was a mantra a few years ago, around doing more for less. But what we need to do is different for the same. And it's possible for everyone to work in a recovery-orientated way, to help people achieve better recovery outcomes. Just to finish by saying, what's the impact of our work? Peer support. We sponsored an external evaluation a few years ago by Byrne and Hunt, and some of the findings were that it increased the opportunities for people to achieve recovery, and it increased the recovery understanding of services, of people who work in the services. The Department of Health, gave peer support its own grade code last year, so that's a recognition of how important it is. The work we do on sharing the vision, we lead on 11 sharing the vision recommendations. They were given to the Office of Mental Health Engagement and Recovery because they were recognised as the best people to deliver it. And we're talking about, important recommendations like, the reconfiguration of day services, the focus on recovery care planning, advocacy, all these things that will bring about real change. This year we hope to launch a new framework for recovery in mental health in 2024, and also a new framework for engagement in mental health. Last year we had over 19,000 participants in recovery education nationally, and that they're not complete figures, and it's not in every area. Through the IPS, the Individual Placement and Support Programme, 458 people went back to work. And all that's achieved because we've brought lived experience into the service. There's about 150 people now with lived experience working across the different programmes, plus volunteers on top of them. And that's what you can achieve by bringing in and working and recognising the expertise that lived experience is, recognising the strengths that people bring, because that's the difference it can make. And thank you all for listening. And I'm now going to hand you over to give you a very practical example to Sharon and Doreen are going to talk about, at a policy level, how you integrate that lived experience into its, design, delivery and implementation. Thank you.
Well done, Michael. That's, I think a really grounding input from yourself. We're now going to hear from two other speakers. Sharon Lane is the chair of the said reference group of NIMIC, and Sharon has worked across community disability and mental health services in government and in non-governmental roles, both here and in Australia. So we're really delighted that she's going to speak, and then she's going to share her time, I believe, with Doreen. Doreen Carpenter is a lived experience advocate who currently works as a HSE mental health service coordinator for Travellers in the CHO9 region. She's a member of the Sharing the Vision reference group, and she has 35 years of experience of working in the community and voluntary sector. So that's some track record. You're very welcome.
Thanks, Gorna, and thank you everyone for being here today. So I'm going to be very quick because Doreen's the important person here to listen to. I'm just going to give you a quick overview of the reference group and our beginnings and where we are now. So in October of 2021, there was a call from the Department of Health and the HSE for a not-for-profit organisation to host the reference group. And the bid was won by SHINE, Ireland's mental health advocacy and support organisation. In January and February of 2022, following a really intensive, which Nicola will vouch for, a really intensive recruitment campaign, the 12 panel members were selected and myself as an independent chair was engaged. And SHINE continued to provide secretariat and advocacy support to us the whole way through, which is extremely important and a big part of what we do. So in March of 2022, which feels like years and years ago, but wasn't that long ago, our inaugural meeting took place. So the reference group, we're joined here today by members of the reference group. We have some ladies over here, and we have some ladies and gentlemen over here as well, and of course Doreen. So we're very lucky to have them with us today because the reference group are a volunteer group. They give up their time freely. They spend a lot of time on this work. They're very passionate about what they do, and they bring significant skills and experience to what they do as well. Membership of the reference group is for a period of 3 years, and it's governed by a terms of reference which outlines roles and responsibilities. The reference group meets in person and hybrid, so we make it as accessible as possible for people from all over the country to attend quarterly meetings and to provide commentary and suggestions to NIMIC. And we do that by, we tried a few different ways. It's been a bit of trial and error. We now have a very streamlined online system, which we're very proud of, even though sometimes I mess it up, but other people fix it for me. So it has been trial and error, but I think we've got it to a stage now, where we're managing to go online, read the reports, everybody puts in their comments, we talk about it, we discuss it in our day-long workshop, and then we revise and we refine and we then all approve. So it has to be approved by all the reference group members. So it's a very, very comprehensive, inclusive process. The time commitment for reference group members is 1 full day per quarter for that in-person / hybrid meeting, plus 1 full weekend, and it's a full-on weekend, to read the reports, provide the commentary, approve edits, and then sign off. And as I said, the reference group members are all volunteers, so they've taken days off work to be here today. They've paid their own train fares, their bus fares. They've got up at 6 o'clock this morning to make sure that they could be here. So you can see there's a real passion for what they're doing, and it's really important as well that it's acknowledged, which it is, I think, by the partners in this process. I think one of the lovely things about the reference group is that we're actually working in real time. What's happening is happening in real time. The reports come to the reference group before they go to NIMIC. So that voice, that lived experience voice, is being really, really enforced and amplified in the process very early on. Moving forward, so continuous improvement is better than delayed perfection, which I think, we strive for perfection. But we're happy with continuous improvement. To facilitate improved communications and shared learning, we, in partnership with NIMIC and the HSE and the Department of Health, decided that it would be really helpful to establish a series of enhancing communications workshops. And that's where we all collectively meet with the workstream leads to talk about certain recommendations that might be delayed, or there might be resourcing implications, or it might just be that they're quite complex and the reference group would like to understand more about them. And that's working really, really well, and it's a shared learning for everybody. We've engaged with specialist groups for sharing the vision, and we've provided a lived experience voice on specific recommendation working groups. So not only are the reference group members attending the quarterly meeting and doing all of the associated work, but they're also sitting on other recommendation working groups as well. The reference group members have attended conferences, they've produced videos, and they've spoken very eloquently of the importance of the policy itself, and most importantly, the inclusion of lived experience in policy development and implementation. So very quickly, the learning to date. I think in order to achieve quality outcomes, what we felt was that the process must be genuinely committed to by all stakeholders in the process, and that there was no place for tokenism. And I can hand on heart say, and across my career, I haven't said it that often, but I can hand on heart say that the authenticity and the buy-in of people in the department, thank you, Philip, and Derek and the HIG and the NIMIC Steering Committee, John and Ian and everyone else, and I'm looking for faces, but everyone who's been involved in this process, it's just been, the authenticity and the genuine commitment has been second to none. And even though we've all had to be patient, we've had to compromise, I don't think anybody feels they've ever had to sell their soul to get to where we've got to at this stage. It's really about the process that we've committed to for implementation includes the analysis by the reference group and the mapping of input and outcomes, by and for service users, and ensuring that lived experience voice, particularly in relation to diversity and inclusion, is considered and included across all recommendations. So that's been a very important part of the process. In terms of performance, clarity of information regarding timelines, resourcing, monitoring and evaluation continues to improve, but we acknowledge that there's still a way to go there. Diversity within the reference group needs to be expanded, and a current recruitment drive is underway to add additional members, as there are still gaps in representation. And development of a well-defined quality assurance process for closing recommendations that have been completed is an important part of this performance management. Our timelines are ambitious, but are progressing well across many recommendations, considering the magnitude of the task at hand. In terms of quality outcomes, greater clarity and consistent in reporting has been achieved, the language is clearer, the monitoring reports are more reader-friendly, and that's important considering how each report is published on the Department of Health website and accessible to everyone. There's a better sense of the reference group's key role in influencing how policy is being implemented and monitored, and the voice of lived experience is gaining recognition for its important role in the policy framework. So the importance of accountability and transparency, we feel, is much more understood over time, not only because of us, but as Michael said, because of all the other lived experience staff working across mental health services. And the systems that are being put into place to support that are also really, really important. And I think in general, there's a clear understanding that there are a lot of good people doing a lot of great work across the reference group, government departments, the HSE, NGOs, and the community in general. So I'd just like to finish off by saying a huge thank you to the outgoing NIMIC committee, chaired by John, and for all of the time you've put in, for the support and the encouragement that you've given to all of us on the reference group, and to welcome Catherine and the new members of the NIMIC reference group, and to say we look forward to working with you in the future. So thank you.
Thank you so much for that overview. Doreen, would you like to come here? Yeah, great. So you're very well. Doreen Carpenter, ladies and gentlemen.
Thanks, everyone. It's great to be here today. I'm going to give you a bit of an insight into my own personal experience of mental health as a family member. My mother in the late 70s had to go into the mental health services, and it wasn't really a good experience for her or our family. We didn't have a good experience, as I said, and when we went to visit her in the where she was, we didn't have a good experience. So that tainted my experience of mental health. I'm happy to say now that has changed dramatically since then, but back then it was really bad, and it didn't help anybody that was supposed to help. But now, as I said, that's where my passion comes to be a member of the reference group. When I seen the advertisement coming up to become a member on the reference group, my passion drove me there, because I wanted to fight for equality, I wanted to fight for justice, I wanted to fight for human rights in relation to mental health and the impacts that's having on it on our communities. I work with the traveller community, and mental health is a huge lot of trauma in the traveller community, and mental health, we need to be putting more support and policies in place. But the minute I started off by saying no health without mental health, I'm saying no policy without lived experience. Because, I mean, if we don't have that, we're not getting it right. For years we didn't get it right, and I'm glad now we're on the track that we are getting it right, and we're all here together for the one thing, to make sure that policy is better and implementation is better for the lived experience and the outcomes and the opportunities that bring for people with lived experience. And the amount of people here today proves that things have changed, and I'm happy to see that as a lived member, a family lived member with experience, that I'm happy to see that change is being implemented. But the reference group, we do, as Sharon says, there is a lot of work in the reference group, but we're there, but we're passionate. We want to see outcome. We want to see the lived experience, and we want to make sure that anyone that has to go into the mental health services to have an experience that's positive and has a meaningful outcome for them. And that's why we do what we do, and that's why we're passionate about what we do. But no policy without implementation of lived experience is never going to work. So I'm happy to hear, Minister, there's new money coming on board. We will be in touch. We will be in touch about that. And we just want to make sure that the policy is done and it's done right, and it is. And I'm glad that we're part of this sharing the vision, because we want to make sure that there is change. I'm going to leave there. I could go on for hours. I won't go on for hours. I'm very passionate about this, as you might gather. I am really passionate about this, but not just for all communities, all cultures, all ethnicities. We need to be making sure that we're all doing it together for the one outcome, better, meaningful outcomes and policy development. Thanks very much.
Well said, Doreen. Thank you so much. I'm going to come to the floor and then I'll come back for some final comments. But we've got some roving mics. If people have a comment or a question from what they've heard, maybe your own experience of lived experience. I know I had a particular experience around going back to college to do a PhD very late in life, 2015. And I had a theory that as a lesbian woman, that people wanted to have their relationships recognised because it was always about rights and entitlements and being left out. And when I did my interviews, I had to completely change my literature review. Now, anyone who's ever done a PhD will know how painful that was, because what I discovered was that lesbians and gays in 2015 weren't about rights and entitlements. It was about belonging. They wanted to belong in their families, in their communities, and they wanted that recognition, which was ultimately about equality and love. So that obviously informed the work that we then did in terms of the marriage equality referendum and talking about equal and equality. So I tell that story because the lived experience shifted a narrative. And I believe that lived experience, where we got mothers and grandmothers to talk about why they wanted their children to be able to get married, shifted the national discussion and gave us the 63% yes vote that we got back then. So, to yourselves. Comment, question? Oh, come on, you were talking at the break there like there was no... I'm sorry, I couldn't see you behind the table.
I'm Nicola, I'm the CEO of Shine, and I think it's important to say that when we started out this process at our first meeting, it's called the reference group for a reason. There was no trust, and rightly so. So the members of the reference group said, we don't want it to be the reference group of service users, family members, carers. They wanted it to be the reference group. And I think the most important thing that's happened over the last while is the build of trust. And we all appreciate that everybody that's come to the table in the conversations in the different parts of the process has come with genuine approaches and wanting this to work, you know. But it is really important that when you bring people to the table with lived experience, that you do it responsibly and ethically. And my concern would be that people go, well, I know Mary, and we'll ask Mary to be on the focus group or whatever, or the project team. When we took it on, we handle supporting people with lived experience. They're on our employee assistance program and everything. I think it's really important that you recognise the silent power that happens in the room with professionals. I'm a social worker by background, but often in the HSE in particular, we're plagued by acronyms. And that can be quite intimidating to somebody that comes in, because the same acronyms can be used for different things, which is very confusing. And so I think it's important when we do so, when we involve people, which we should do in everything, that we do it with a mindset of empowering them so they're equal. So, you know, it's that saying of, you don't want a seat at the table, we need a new table. You know, that's it.
Very good. Another comment, question from the floor? Okay, there's a woman there at the second table on the left. Thank you.
Thanks very much. Ber Grogan from Mental Health Reform and former Dublin Northwest constituent. Delighted to be here today. It's so lovely. Just to say, I love Doreen's point about no policy without lived experience. So my question for the panel is, how can we ensure that we are hearing the voices of lived experience, that we are getting the diversity of seldom heard voices, but also then when it is in a voluntary capacity and people have other commitments outside of the work that we're doing. So I'm just wondering, we all are striving to be better at it, including the government departments and that. So how can we create better systems to allow the participation of people with lived experience?
Right, thanks, Per. And maybe put that to the panel, you know, each of you coming from your own experience. You know, it sounds like the work that Shine is doing is about recognising that this work, you don't just fetch up into a room and represent, say a few words. So maybe, Doreen, we'll start with you first of all. In your view, how could the supports be, how are they, how could they be improved, and what are the challenges when part of what you're doing is, you know, sharing personal stuff and lived stuff?
I suppose from my point of view is, when I got involved, I've been in the community for a long time and I work in the HSE.
Yeah.
But for anybody that doesn't have that experience or that connection, it is very hard to engage. And I suppose if we done a number of consultations in different communities and said this is what the work we're trying to do, we might get buy-in that way. Because if you're building relationships, you're going to build connections.
Right.
And I think that's how you do it.
Yeah, that's very good. Thank you.
I guess a big part of it is stigma reduction as well. We've come a long way, but still a long way to go. And, you know, if we look around the room, it's not just the people sitting here, it's not just the reference group. There's everyone in the room is touched by this in some way. So it's about how do we make it inclusive and accessible for people to enable people to feel comfortable about saying, yes, I have a story to tell, I have some experience I can bring to this table, this policy, and to really then provide support. So it's, you know, there's a follow through there as well, because people have to be supported through the process. You can't just sit somebody down at the table and then say thanks very much and leave them. So I think there's a system that needs to be put in place.
Very good. Thank you. Michael, from your perspective.
I think it's looking at, I suppose, the values of engagement and recovery. And, you know, engagement is everyone's business, so we can all do it. So it's everybody in their roles thinking about, you know, the end point of this, you know, who the end person is, you know, how is this going to benefit them, how is this going to help them. And it's about bringing the perspective in as much as we can. And we have a model here that we have put in place with Shine, and they can offer a lot of support, and that's really important, because, you know, the HSE is a very complex organisation, so people need support to understand it's working, and, you know, to gain the maximum benefit of bringing people with lived experience in, we need to be able to support them, and we're learning from that all the time, and we're recognising it. And within the HSE itself now at the moment, we have just introduced a support programme similar to employee support, but for volunteer support with an external organisation. But I suppose I would reiterate that point, you know, it's you know, we all have to think about, you know, the values we work with, and, you know, that it's all our responsibility to make sure that lived experience is supported and incorporated into what we do every day.
Absolutely.
Can I just say, it's also about making sure that when we are trying to engage people, that they know it's not a tokenistic role, that it's a meaningful role, and their contribution to that will make changes and develop policies for future generations.
Exactly. Because that time and energy that people are giving, they need to know that this is not just a token. Exactly.
Yeah, and I think in that regard, like, there is applications of lived experience, so we need to know when we're recruiting somebody for a group or a panel, you know, what exactly perspective do we want, so that we get the right people. But the more we understand about lived experience, you know, the more that will develop, you know, because it is a new expertise and a new discipline almost.
Exactly. Well, thank you to the three of you. I think the nothing about us without us is really one of the underlying themes coming through. Just to thank each of you for your work and for preparing your presentations for today. We really appreciate it. Thank you so much. Okay, so moving along, our next session taking us up to lunchtime is looking at the area of youth mental health, and this has been mentioned already this morning. I think obviously we're aware of concerns around this issue and the need to get it right for our children and our grandchildren indeed. And I'm really pleased to be able to invite Donan Kelly, who's the HSE Assistant National Director for Child and Youth Mental Health. And he's going to look at youth mental health and the work of the new office for child and youth mental health issues. Donan, you're very, very welcome.
So, what can I say? We were very happy to be invited here today to talk about the Office of the Child and Youth Mental Health Programme. And particularly because we are a new office, we were established just a little over 3 months ago. I think probably the icing on the cake today is the announcement by the Minister, which has obviously made it so much more worthwhile coming along to this conference and sharing the good work that we're going to do. So I think it's important to know in terms of where we're at the moment, we're pulling together a programme of work. We expect this will be over a 3-year period, but I'm delighted to kind of share kind of some of the overview of where we are at the moment and some of the immediate priorities that are going to be boosted certainly by today's announcements. So just moving along, just to give you a bit of an overview of how we've set up the Child and Youth Mental Health Office, its governance and delivery, and I think importantly, reflecting on some of the conversations earlier today, certainly what we know in terms of our feedback on services and what we have to work with. So again, focusing on the fact that from a health economics point of view, it's not necessarily always about the investment, although certainly it helps, so we're not going to say no, but it certainly is more about what we have and how we develop that going forward, and looking at some of our key objectives over the course of the 3-year programme and our priorities for this year. And I think a look particularly, given the discussions earlier today, on our current and future models of care for child and youth mental health. So I think, as was discussed earlier, there's quite a lot of research out there already existing in the system in terms of what an effective child and youth mental health service looks like. And I think in terms of that, this kind of aligns with the overall vision of our new office. When it's needed, that all children and young people can access appropriate, clinically excellent mental health care, which is delivered in an integrated, person-centred and equitable way. And I think to bring together kind of our team, we're a small team at the moment. There's me as the Assistant National Director, our clinical lead, Dr. Amanda Burke, who many of you will be aware of, and a further 3 people with the support of our wider National Mental Health Office in terms of the programme at the moment. And in terms of our purpose and plan, really is to oversee and deliver programmes of work to improve the quality of child and youth mental health services in Ireland. I think this is bringing together kind of a combination of the recommendations from the Mental Health Commission report, the MASCI look-back review, our audits and the audits that have gone on over the past year in terms of child and youth mental health services, alongside sharing the vision and our clinical programmes as they pertain to child and youth mental health. And I think it's really important that people understand the read across. It's about bringing, not working in a siloed way, bringing those programs of work together to deliver outcomes for children and young people. So if we look at, say for instance, the read across, 49 recommendations from the Mental Health Commission in terms of how child and youth mental health services can be improved in this country. 31 of those sit within our national mental health policy, sharing the vision. So it's not that we don't know what we need to do, we need to get on with the implementation of it. And also, I think the clear piece around our clinical programs. So if we're moving to a child and youth mental health model, we have a clear way of delivering evidence-based care, and that is through those clinical programs. If you look at some of the difficulties that our children and young people face in this country today, it is the fact that there is quite a gap between services in terms of how they're delivered and the interventions that they're getting. And the classic example, we probably heard it mentioned earlier, is ADHD services. So it's great to see the development of adult ADHD services, but we know in the past and still ongoing for a number of children and young people across this country, when they reach 18, those two pathways don't necessarily align. And eating disorders are very much the same in a similar kind of pathway. People aren't necessarily cured when they turn 18 and need ongoing support. So delivering evidence-based, clinically informed programs that join up the pathway across the age spectrum, all the way from children, all the way through to youth, and through to adults and older adults, is a key part of the clinical programs and a key part of this work going forward. I think we've just had our mental health recovery and engagement workers here with us, and I think a key to this is us working in partnership. So it is about that co-production of this programme of work going forward and implementing those evidence-led care models. And when I say co-production, that's co-production with our service users, not only in terms of service user feedback, but the whole level through. So co-production up to leadership in terms of how we roll out services across the country. And I think we need to do that in order to deliver the improved outcomes that are required for children and young people in this country. And as part of the ongoing process to continue that programme of evaluation of impact and effectiveness. So there is a read across to the Sharing the Vision implementation group at the moment, and when we were setting up the programme, the service improvement programme that's been sitting at the moment has been under the auspices of the National Oversight Group for Child and Youth Mental Health that reports directly through to the HSE board to bring that assurance along all the work that's been done around the MASCA review, the Mental Health Commission report, and bringing on the service improvement work. As we say, we'll be working jointly across the programmes of work, working closely with our colleagues in NIMIC, and we will be in part of NIMIC, but also wider as well across the disabilities piece, thinking about the new children's roadmap strategy for children's disabilities, and that there are key links across between ourselves. There are a number of recommendations that sit there. There's 105 in total sitting with this office at the moment, and in order to do that, we have established the Child and Youth Mental Health Programme implementation group and 3 broad delivery groups to progress that work. Sitting under the 3 common themes that sit there, and that one is around improving the clinical delivery of services, the overarching governance that sit around our child and youth services, and then those enabling functions that we know are really important in terms of delivering change. So that is our IT functions in the States across the piece. A bit onto what we know so far. So certainly a lot of great work has been done through the Sharing the Vision programme so far, jointly with Spun Out, in terms of that service user engagement with young people. And what we know from them is that they have difficulty retelling their story time and time again as they go through services. There's difficulty in terms of accessing services. Quite often there's long wait times and unclear criteria to access specialist services, and that difficulty when we're talking about transition. At the moment as well, we're moving around the country, engaging with all the CHOs and all the services, getting to meet local teams on the ground to understand that service variation and what's causing that, and also some of the difficulties that are coming up from a staff point of view in terms of the recruitment challenges, IT systems that either aren't there or fit for purpose, and some of the unclear governance structures, funding and resourcing challenges, and cultural barriers. And these are all things that are important to bring together in terms of that programme going forward. These are the key things that we need to address, as well as what's come out from the Mental Health Commission report and the MASCA look back. I think, though, it's really important that we cannot stress actually what we have at this particular point in time. So we have a great voluntary and community sector partners across the country, and that ranges from national leads such as Jigsaw and Pieta and Mental Health Ireland, down to individual services that are delivering things for children and young people in individual corners of the country. So thinking about Southwest Counselling Service down in Kerry when I was down there recently. We've got a really vibrant system there that are delivering important interventions for children and young people and should be integrated as part of our clinical pathway going forward. That's how we deliver change and open up accessibility. We've got well-established CAMHS community teams and inpatient services, and we have a number of wider supports for children and young people that sit across disability services, primary care, and digital rollouts that are going on at the moment. And I think in terms of our move towards standardising and removing unwarranted variation in care, a lot of work has been done around the CAMHS clinical operational guidance, and we've got a whole programme to refresh that this year in view of updating and expanding some of the remit there. I think it's probably important to say as well, we've got a committed and highly skilled workforce that sits within services. Now that's regardless of whether it's within our VCSEs or it's in our statutory CAMHS services, and who continue to be very committed in terms of the day-to-day delivery of services, and who spend a lot of time in some quite challenging circumstances at times, delivering those services and really have a focus on children and young people's mental health. And as we've mentioned, the reason we're here today, we've got a great national policy that is promoting the continued expansion of comprehensive services and also the support from our partners in government and the Department of Health in terms of achieving those realisations. So I think I'm not going to run through all of these. I will just kind of skip over kind of our key objectives of the programme. And it is for children and young people to receive timely, clinically appropriate care, for all services to achieve sustained clinical excellence, and there is no reason why Ireland is not in a position to lead in the development of world-class models of care, given the policies that we have there at the moment and the investment that's coming in. And we also need to look at our enhanced data management to inform service planning and measurement-based care, and I'm specifically speaking about our IT systems. So I think in terms of some of the key priorities for the CYMH office in terms of 2024 is the continued initiatives to reduce CAMHS waiting lists at the moment. So the CHOs have all been involved in reductions in CAMHS waiting lists. We're also looking at telehealth options to further supplement that. And we've also recently been awarded funding under the Slongicare programme to roll out an analysis in terms of how to improve wait times across the system. I'm pleased to announce after the last National Oversight Group last week, we've got sign-off not on an interim IT system, not on a temporary solution, but actually on the rollout, to start the rollout of an electronic patient record. And I cannot say what a game changer that will be for most services who are largely working on a paper-based system, both in terms of outcomes for children and young people, not having to retell their story, measuring outcomes, and also in terms of the administrative burden that sits there at the moment for clinicians that are working in services, so improving the overarching governance. We'll have a continued focus as part of the programme on looking at our governance structures and improving our operational performance, and updating the CAMHS operational guidelines and removing that unwanted variation that we see within services so that we deliver better outcomes for young people. And as has been mentioned in some of the other sessions, certainly we need to look at the workforce and the recruitment and retention of staff. We're looking at a bespoke recruitment campaign being launched in the HSE this year, deliberately to address some of the deficits, notwithstanding some of the current difficulties and challenges we have in terms of recruitment pause, but also thinking about those new service developments that we've talked about already today and the ones that we're going to find out more about tomorrow when we meet with the Minister and the Department of Health. So lastly, I think kind of the main other piece of work that we're going to be looking at this year is kind of around our model of care and service delivery across the country. As you may well know, most our current kind of provision is based on a tiered step care model of care. And whilst that has been useful in terms of how we plan and deliver services, differentiating between the different forms of support, and it's been useful in terms of how we organise our services, it does have its difficulties, and this is well known from an international research point of view. Young people in a tiered model have to fit themselves into the specification of the service. And as we know, young people are quite complex. They have multiple needs, they have multiple difficulties, and there are multiple supports out there. We often know that within a tiered model of care, when we have demand issues, when we have restrictions in terms of capacity, what we start to see is higher thresholds implemented within those services as well, further creating barriers. And this creates division between services, and you quite often see young people bouncing between services and those duplicated waits. So we know that, for instance, that somebody might access primary care services and might wait to do that. They might get a program of care, they might need further help, and as they go back in to see another specialist, they will wait again. So we need to look at how we move away from that. And as we're moving to trauma-informed models of care, we really need to move away from retelling the patient's story at all those points in time. So I think moving on really is kind of what is that future model of care, and how do we move away from that tiered service, bringing together all the great resources that we have at the moment across the country. And we've talked about the VCSE resources, we've talked about education, we've talked about our primary care services, but actually, what does a young person-centred mental health model actually look like as we move forward? And we know for the vast majority of children and young people, they get their supports from those in the inner circle. It is their peers, it is their family, it is their carers. And as they move out, it can be also their schools, their colleges, their community. And then it starts to hit more statutory services. So services need to be wrapped around understanding that actually working in a systemic way from a CAMHS perspective, you need to bring in all those supports at various times to be able to do that. And that means moving away from this tiered model where we bounce people between services more into a greater emphasis on prevention and early intervention, and a focus on improving outcomes through getting people accessible, timely care. Part of what we will be looking at this year is rolling out that kind of single point of access. So we've already started and initiated discussions with our colleagues across primary care and disabilities. But for children and young people, that needs to sit across the spectrum. It needs to sit across our VCSE partners at both a national level and a local level in terms of creating that. What we know from the evidence from both Australia, from Canada, from the United Kingdom, who've gone through Origin, integrated youth health services, and the iThrive model, is that actually creating those single points of access and moving to a youth-centred model of delivery of care has increased accessibility and improved outcomes for those young people. So I think in terms of where we're at, I think I'd like to finish there and move on and open it up to any discussion. Thank you.
Thanks very much for that. Thank you. Okay, so far be it for me to keep you from your lunch, but I think there may be one or two questions. Left-hand side, man with his hand up down there. And I'll take another one or two if they're here, and then we will... Yes, please. Second man there. Okay, let's take those two. Thank you very much. Has your microphone come to you?
Hi, thank you. My name is Kieran Moore. I'm a consultant liaison psychiatrist in Crumlin. Just to say thanks for the presentation and the whole day. I don't want to be looking at deficits, but the one thing that hasn't been mentioned at all is liaison psychiatry, and that does need to be looked at, because actually there is no system for recording the amount of patients that come in, and I suppose particularly a lot of patients that would normally be admitted to a specialist centre, specialist psychiatric or CAMHS are admitted there, so we need to. And I suppose also urgent cases generally go to GP or to ED. So I'm concerned that's not even mentioned. So we need to look at it. Thank you.
Thanks very much for your question. And yes, please.
Hi. Thanks for the presentation. My name is Niall Muldoon. I'm the Ombudsman for Children. And just checking with the establishment in your office, which is fantastic. is this the start of us finding out how much is spent on children and youth mental health as a distinct figure? Will we have a budget over the next year, 2 years? Will we know exactly how much is spent out of that 1.3, and it's not just add-on or something we're unaware of? So hopefully that's the start of moving in that direction.
Okay, thank you for those two.
Okay, so maybe to start with the question about liaison psychiatry services. Yes, liaison psychiatry services are an important part of the overall comprehensive system of child and adolescent mental health services that we need to provide. So I didn't specifically reference it within the presentation. I think what I referenced was the development of further models of care and that wider growth in terms of services. So that sits across not only our integrated VCSE partners, but also in terms of our different stratified levels of service that sit within CAMS. So thinking about liaison services, thinking about our crisis services, our CAMS hubs. It is part of the broader picture, so certainly it's not discluded. And the reason I flicked back was because I just wanted to reassure you on my future model of care up there, CAMS liaison certainly mentioned on there. Whilst we were talking about it in a general context in terms of those service developments going forward, those things are contained within Vision for Change, the National Mental Health Policy, and they will be things with further investment we will be rolling out. It is about partly that kind of multi-year plan. We know we've got workforce difficulties at the moment, and we best need to put the infrastructure and the funding into those services that are going to deliver the most effective improvements over the coming years, and they're certainly part of that.
Okay. And the second question about funding.
Yes.
Ombudsman for Children.
So, in terms of a dedicated budget, this does sit within the HSE itself. I think we do understand what the current budget is from a child and adolescent mental health point of view within services, but at this point in time it is grouped in with the wider mental health budget. But we do know in terms of the new developments that are happening at this particular point in time, there is specific remit and funding around the Child and Youth Development Programme, which is really welcome to hear, and a bit of a shift away from perhaps previously how things have been managed.
Okay, folks, it's 1:05. Can I ask you to be back here for 2? The Minister for Health will be welcoming you back, so I'd ask you to come on time. Enjoy your lunch. Thank you very much. Thanks so much, Donan. Thank you.